In this lecture, we're going to talk about vertigo. And that is one of the most important things that you can do clinically. When someone comes in saying they're dizzy, that is a useless complaint because it doesn't mean anything to you. And you'll find that some patients have a very tough time separating out disequilibrium, presyncope, and actual vertigo. So that's what we're going to start with. When someone comes in saying, Doctor, I'm dizzy, the first thing you want to do is determine what do they mean. If what they mean is they have a sensation of blacking out, or that they might pass out, or they actually have had a loss of consciousness, what they're talking about is presyncope and syncope. If you want to learn about syncope and presyncope, check out the cardiovascular lectures as well as the intern content. Go through syncope. This is a big deal because if someone passes out, it may imply they have a cardiovascular issue which can kill them. Vertigo, on the other hand, isn't necessarily benign, but does not have a thing that's going to kill you right away. If what they mean is that they have the sensation of the room spinning, or they are unsteady on their feet, and no loss of consciousness, they mean vertigo. But vertigo isn't enough, because now you have the task of deciding, is this central or is this peripheral? And as we'll see, central lesions are more ominous and require imaging, whereas peripheral lesions do not. And the way you're going to make the decision is by finding out what else is wrong, what nearby is broken. Remember, balance is in the ear. The vestibular system begins in the semicircular canals of the ear, and along with hearing, go via cranial nerve 8 to the brain. Hearing and balance are in the periphery together. In the brain, you'll have brainstem reflexes. That's where cranial nerve 8 drops off the vestibular system. So if you have ear symptoms, that is either tinnitus, also called tinnitus, both are appropriate, or hearing loss, but no neighborhood signs, no brainstem lesions, and no focal neurologic deficits, now you're in the camp of peripheral. No imaging going to be needed. On the other hand, if you don't have tinnitus and you don't have hearing loss, though you might, let's keep it binary, you do have neighborhood signs in the way of brainstem lesions or focal neurologic deficits, including cerebellar signs, now you've dumped into the bucket of central. And what central means, central vertigo, is a product of posterior fossa insults. And in order to figure that out, you get to the MRI. Let's start with the central lesions, the posterior fossa stuff. Posterior fossa lesions come from a number of potential causes. The ones that you are going to look at the most are multiple sclerosis, stroke, and tumor. But don't forget about things like an abscess, complex migraines, and weird seizures. The patient is going to present with focal neurologic deficit. This is almost always going to be in the way of cerebellar signs, but no ear symptoms. If you see focal neurologic deficit along with vertigo, the diagnosis is made by obtaining an MRI, and the treatment is going to be disease-specific, and this makes sense. You're going to irradiate a cancer, drain an abscess, but you can't fix stroke. I just want you to see this. So we've talked about posterior fossa, but really where I want to go with this lecture to finish us off is the 3 different peripheral vertigos you should be able to identify. And the first one is benign paroxysmal positional vertigo. The pathology of BPPV is an otolith. In your vestibular system, you've got these hairs in this fluid. And so as you move around, those hairs get tugged on and they activate. That tells your brain that you're moving in space. If you have an otolith floating around, touching one of those hairs, the brain interprets you as moving, even though you aren't, and that produces the vertigo. And the patient is going to be very obvious for BPPV. They're going to present with recurrent and reproducible vertigo. And that vertigo is going to last for less than 1 minute. Usually you can get it on the history alone. And as you'll realize, peripheral vertigo does not require imaging. The diagnosis is made with physical exam only, called the Dix-Hallpike. And the treatment is also with a maneuver, the Epley maneuver. And essentially you're just getting the stone out of there. So BPPV is going to present when someone lays on their left side, they get dizzy. Every time they do that, they get dizzy. But if they just sit there for a while, they don't have any problem. When they sit up, they get dizzy. But as long as they remain sitting up, they have no problem. And it lasts for less than a minute. That's BPPV. The second thing is we're using Dix-Hallpike maneuver to look for rotary nystagmus. This is a simplified version of the physical exam maneuvers. So if you're on a neurologic rotation and you're with somebody who deals with vertigo, extract from them all the details about the physical exam, which direction the nystagmus is beating, fast versus slow, in order to determine central versus peripheral lesions. What I want you to remember, Dix-Hallpike rotary nystagmus, BPPV. Compare BPPV to vestibular neuritis. Now, vestibular neuritis is essentially the same thing as labyrinthitis. Labyrinthitis has hearing loss. Vestibular neuritis does not. The pathology is post-viral. Now, we're pretty sure that this is wrong, but this is the best answer we have, so that's what we can keep saying, and that's what you might see on the test. The patient is going to present 4 weeks after URI. And the problem with this is that most patients don't remember that little cold they had a month ago, and they certainly do not associate that cold with their vertigo they have right now. So if a patient presents 4 weeks after a URI and has vertigo, and that vertigo lasts 1 to 10 minutes whenever they have it, and there may be an associated hearing loss. The hearing loss makes it labyrinthitis. And there may be nausea and vomiting. You might begin to think without the URI that this is a central lesion, and that's okay. This sometimes gets brain imaging, and then it's negative. The diagnosis is made clinically, and it is very similar to BPPV in the sense that they have the vertigo, but it lasts much longer, 1 to 10 minutes at an episode. The treatment for labyrinthitis and vestibular neuritis is frustrating. If the person happens to come to you and says, 4 weeks ago I had a viral illness, now within the past 24 hours I've had this terrible vertigo, you can give them steroids. Steroids will decrease the duration of symptoms. But really, people who have this just have to wait it out. And so what you're going to use is anti-vertigo medications such as meclizine to make them feel better. The thing is with labyrinthitis, it's going to last for about a week, but then it will persist with these little vertigo episodes for up to months. Very frustrating, but nothing you can do about it. And since it's viral, there's nothing you can do to prevent it either. The rarest of the three is Meniere's disease. We have no idea what causes it, but the patient will present with a triad of hearing loss, tinnitus, and vertigo. And these episodes of all three occurring together last less than an hour, but more than 30 minutes. The diagnosis is clinical, and we don't know why this works, but it does, so we do it. Salt restriction and thiazide diuretics. Because this is going to be with them their entire life, they're going to suffer with it, so put them on anti-vertigo medications, meclizine. So what you should have gathered from this lecture is the first thing to do is figure out, do they mean syncope or vertigo? If they mean vertigo, use your physical exam and the history to decide it's central or peripheral. If it's central, get an MRI to find out what's going on back there. If it's peripheral, use the timing and what sets on the vertigo to separate BPPV from labyrinthitis from Meniere's, knowing that you can use a physical exam maneuver to treat BPPV, steroids to treat labyrinthitis, and salt restrict and thiazide diuretics for Meniere's. That's weakness.